Good evening. It's a pleasure to welcome you to today's ESDS webinar on lung volume reduction surgery, where we will have a new format for the webinar. It's going to be an Oxford-style debate. And I'm happy that we have David Waller from the UK and Lawrence Ceulemans from Belgium, two surgeons which probably need no further introduction and who both are well versed in the topic of lung volume reduction surgery. And David will start with bringing the position of unilateral LVRS, and Lawrence will propose his arguments for bilateral LVRS. And after rebuttals, we'll have a Q&A session with all questions of the audience. So if there are any issues you want to raise or questions you want to ask, please put them in the chat or in the Q&A tool, and we'll discuss them afterwards. So I'm very happy to have two such renowned speakers here, and David will start with your presentation.
Well, Clemens, thank you very much for the invitation. I have been involved in volume reduction surgery really since its inception over 30 years ago. And I have now retired from clinical practice, but I continue my interest. I'm working for the Pulmonx company now as a medical advisor, and I'm still trying to encourage surgeons to take up the whole range of volume reduction procedures. Just try and share my screen with you. Okay, so I'm going to explain to you why over the years we developed a strategy of doing unilateral volume reduction surgery, because we believe, and I think we proved, that it had the most durable benefit. It's very important always to start with our selection process, and this has been modified over the years, and this is a summary of the selection we have used. The patient has to be breathless, MRC grade 3 to 5. They have to be breathless due to airways obstruction, and we looked for an FEV1 of between 20 and 50% of predicted. And the breathlessness needs to be due to hyperinflation. That is the key word in volume reduction. And really, the greater the residual volume, the better. I personally would look for a residual volume of greater than 200% of predicted. Once we've satisfied those criteria, they need to have target areas. This can be determined by combining the information from a CT scan with the emphysema destruction and a perfusion scan to give a functional map of the lung. In later years, we've been using a SPECT CT scan to fuse the images. The determination of which method of volume reduction is largely based on the presence or absence of collateral ventilation. Endobronchial valves can't be used if there is significant collateral ventilation. This can be assessed intraoperatively, but that's a talk for another time. It's very important to assess the risk for the patient. They should be excluded if they have evidence of severe hypercapnia, severe pulmonary hypertension, or right ventricular dysfunction. And those are parameters that are decided at a unit level, depending on the facilities available. We use a risk score that we calculated using three simple parameters: the body mass index, the FEV1, and the gas transfer. All cases should be discussed at a multidisciplinary team, and we have developed specialized LVR clinics with dedicated database and dedicated staff. We started in the 1990s as we were taught by Joel Cooper with a median stenotomy and bilateral volume reduction surgery, which had a relatively high mortality. We then, with the advent of video-assisted thoracoscopy, developed a bilateral video-assisted thoracoscopic technique, but we still had problems with high morbidity, and we found that the high initial benefit soon declined. We then switched to unilateral video-assisted thoracoscopy, and as I'll show you, we found similar improvements, but much reduced morbidity. In later years then, we've gone on to use endobronchial volume reduction in our program, and in the UK, the surgeons put in the valves as well as doing the operation, which gives us that extra tool in the toolkit. There have been reports from other centers of a staged bilateral video-assisted procedures. Eugenio Pompeo's unit from Rome was the first to report at an interval time of 15 months, and they again found that there were durable improvements in both physiology and survival. They also found that long-term improvements are more stable from a staged approach rather than one-stage bilateral. Similarly, Bill Walker's group in Edinburgh, at a median of 9 months, in a small group of patients, found that they were able to prolong the benefit of the initial surgery. But these programs, the operation, the staging was decided by the surgeon. The data I'm going to show you now comes from the experience, the 20-year experience I had in Leicester at the Glenfield Hospital, and I'll take you through the story of how we developed what we ended up doing. So this was an initial publication of comparing a unilateral versus bilateral approach. This was when we'd done a very small, it's our early experience looking at those patients who had unilateral, who were all suitable for bilateral. It's very important. The patients had bilateral targets. And the significant difference was that if you do one side, you do resect a lower volume of lung, a lower weight of lung, but there was significantly lower ITU usage, post-operative stay in the hospital, the requirement for post-operative ventilation, although the 30-day mortality was fortunately low in both groups, so there was no significant difference in mortality. But certainly there was less use of hospital resources. And interestingly, we found that in the one-stage operation, there was a significantly better improvement in FEV1, but not so staggeringly better than the two-stage patients. However, the subsequent decline was significantly more in the one stage. And that is the important message, that you get a better initial benefit from doing both lungs at the same sitting, but you prolong the benefit with lower decline from doing two lungs at a stage procedure. Similarly, we found no difference in health status up to 2 years after the operation. So in the initial benefit of the operation and quality of life, there was no benefit from doing both lungs at the same time. We let our patients decide. So unlike the groups in Rome or Edinburgh, we didn't dictate to the patient when they should have the second operation. This was a bigger group of patients. It was a later publication when we looked at those patients who'd had one-stage bilateral by both open and video-assisted surgery, and those that had unilateral operations, with the second operation not scheduled until the patient said they wanted it doing. So we had regular follow-up, regular lung function tests in the post-operative period, and the patient was the determinant of when they had their second operation. As you can see there in that middle group of figures there, which is the FEV1 at the top, the residual volume at the bottom, you can see what happens after about 4 years when the patients decided their symptoms had worsened. They got a second operation and a second significant improvement in both FEV1 and residual volume that wasn't seen in those patients who had a one-stage bilateral, who all had significant improvements, increase in FEV1 and decrease in residual volume initially, but then that benefit declined. But the two-stage patients got a second boost. The unilateral patients, as you can see, they deteriorated without any further interventions. And similarly, in the health status measurements, there was a second boost, in fact, a maintenance. In that middle group of patients who had a staged procedure, we managed to keep these parameters of the short form 36 quality of life questionnaire above baseline for a much longer time. You see in the physical functioning parameter at the top, the one stage bilateral got a significant benefit, but that tailed off. Whereas those that had bilateral stage procedures, we managed to maintain their physical function. Similarly, for social function and energy and vitality, which are probably the most important parameters to the patient. And importantly, the long-term survival was not reduced by staging the procedure. There was similar survival for those that had one lung done at stage procedure and those that had both lungs done at the same time. This was our final publication after we started to use endobronchial valves as part of the strategy, when it got more interesting. This is a series of 331 procedures on 254 patients. So this is a long follow-up, thanks to Inga, who was our clinical fellow who sent questionnaires to these patients and ran the LVR clinic for nearly 20 years. We had a longitudinal follow-up of these patients. There were sustained improvements over where they started in the Euroqual 5 domain and the short form 36. The Euroqual for up to 5 years and the short form 36 for up to 9 years after they started. The median survival was 5.6 years. The overall 30-day mortality was only 3%. So we were happy with this result. We maintained a long-term benefit, a durable response by mixing and matching and staging procedures. And so this is the sort of map of what we did. You can see the commonest start was a unilateral VATS procedure. The second stage was most commonly a second VATS. The third stage, and yes, some people did have a third intervention, was either another VATS or endobronchial valves as they started to come in. And so the commonest route was VATS, VATS, valve. But also some patients had valve, valve, VATS, and we mixed and matched. Interestingly, as you can see, only 3 of those 254 patients ended up with a lung transplant. And that reflects the practice in the UK and also the age of the patients in which we were operating. In terms of the technical aspects, we did triportal volume reduction surgery in Leicester by video-assisted thoracoscopy, in London subsequently by robotic surgery. We did buttress the staple lines when we started. In the later days, we didn't buttress. And endobronchial valves were put in under general anesthetic using the Zephyr valves. The learning points were it is possible to do volume reduction after endobronchial valves if they're a non-responder without removing the valves. It is possible to put valves into a lobe after you've done volume reduction surgery. Now that is more tricky, but it is possible. If that residual lobe, the target lobe, re-inflates, you can insert endobronchial valves. The bronchial anatomy is distorted, and you may need to use low profile valves and the J catheters to get around some of the distorted bronchial anatomy. We did redo VATS. We'll talk about that later, but it was associated with increased air leak and, of course, the risk of conversion to open thoracotomy and the subsequent morbidity. This is a case of a patient in our series who had bilateral upper lobe targets, relatively young female. She had right upper lobe endobronchial valves, but you can see there and the successful result from the endobronchial valves with collapse of the right upper lobe. But as you can see there, 3 months after the valve insertion, what had happened to the left side, there was compensatory hyperinflation, and the patient was actually worse than when she started. And therefore we did lung volume reduction surgery. She was only suitable for valves on the one side, and we went back and did lung volume reduction surgery on the left side, and you can see there she had a very much improvement in her quality of life and lung function from valves on one side and volume reduction surgery on the other. This is an example of putting a valve in after volume reduction surgery, baseline hyperinflation, right upper lobe video assisted thoracoscopy and volume reduction surgery, and then insertion of endobronchial valves into the right upper lobe when that target lobe reinflated in the longitudinal follow-up of the patient. And this is the key thing. In the stage group, the red line, the health status was maintained better than baseline for up to 10 years in those cohort of patients at that time who progressed through our program. So we maintained them better than when they started for a decade, which is, you know, I don't think we could have bettered that. And if we look at the individual domains of those patients at the bottom, you can see in all the patients there were 2 to 4 year improvements in the domains in physical and mental health in the short form 36. But if we look at the bottom, the stage patients, look how much longer they got benefit, both in the physical domains and the mental domains. So look, you get a 9-year benefit in the energy of the patients and an 8-year benefit in their social functioning. And that really is what the patients want. They don't come into the clinic and say, my FEV1 is better. They come in and say, I'm now able to do, you know, play with my grandchildren, exercise, do things I was never able to do. And I think that is the absolute outcome we're looking for. There are problems. I will be honest that there are problems. And of course, the main worry is that people who are making the decision themselves wait too long. This was an early assessment of 43 patients, and 26 went on, of that 43, 26 went on to a second stage, but 17 were unsuitable. Now, there were some reasons that were out of the control, as some only had one target, some had developed a cardiac risk, some had died whilst waiting, some declined, and some were too good, of course. But there is a possibility that there may be deterioration in gas transfer, such that they've become too risky. They may develop secondary pulmonary hypertension, and they could lose their target heterogeneity with worsening of the emphysema. So this is a risk with waiting. You can see that the median interval between the two stages was 4 years, and at that time, 23% of those patients had died within 4 years. So patients can die before they make the decision. That's not to say they would ever be suitable, but they may have missed the boat and may have died from the disease. So, in favor of a stage procedure is the reduced initial risk and use of hospital resources. It gives the patient the possibility of coming back for a boost in several years after their first operation. Gives them something to look forward to. And if you time it correctly, such that they don't deteriorate too much, you can maintain their health status above baseline for many, many years. It removes the risk of redo surgery because you can give them something on the native unoperated other side. However, the cons, I'm sure Lawrence will talk about this, is that there is a smaller initial benefit. You can get compensatory hyperinflation of the other lung, so you can run into complications that you may need to make a decision before the patient does. And there is the theoretical risk of repeated operations and hospital treatment. And the main risk, of course, is of missing the opportunity of the second side due to disease progression, or the patient may die from complications of their disease. We don't know, they wouldn't have died anyway, but there's still the risk. If you leave it with the patient, they may wait too long. So in conclusion, what we found, it was possible to combine lung volume reduction surgery and endobronchial volume reduction in the same sort of strategy, which we had a unique opportunity to do that because we were in control of both of those modalities. Discussion at the multidisciplinary team, however, is the mainstay, and it's vitally important to involve physicians with an interest, radiologists, physiotherapists, and have a good admin support. Despite the shortcomings, I still think that this operation is for quality of life, and the patient is the best determinant of their quality of life. Providing they're not lost to follow-up, I still believe it's best to let them decide the timing of the intervention. We think the staged approach results in a sustained benefit over many years. And don't forget, this is after medical therapy is completed. These are patients who have reached the end of medical therapy. And it leads the possibility for future interventions and something for the patients to look forward to. So we showed the early results, showed a more prolonged strategy, showed sustained benefit. But they need to be warned not to defer the second stage for too long. But we felt justified, and we continue to do that. I think many of the centres in the UK have adopted the procedure of a staged bilateral approach. Now, I think Lawrence is going to quote this as well, and I've no shame in quoting this. This is the fable of the tortoise and the hare. Dates back to Aesop. And basically, the motto, if you're not aware of this fable, is that the hare shoots off and gets so much faster and gets well in the lead, but then relaxes and goes to sleep under the tree because he's so sure he's going to win the race. The tortoise keeps going at a steady pace and doesn't stop. And by the time the hare's woken up, the tortoise has crossed the finish line. But the moral of that story is that slow and steady wins the race. And I think that is, for me, the moral of volume reduction surgery. And that's why we've done the staged approach, the slow and steady approach with a greater overall benefit. Thank you very much. We'll come back for a rebuttal in a few minutes.
Thank you, David, for this balanced overview on the durability of the unilateral approach. And now we're looking forward to the opposing view of the best functional improvement provided by bilateral LVRS by Lawrence.
Thank you, Clemens. I hope you can see my slides. Can you confirm that?
Yes, works perfectly.
Thank you very much to the ESTS for the opportunity of the presentation. It's a privilege and an honor at the same time to debate with Mr. Waller on this topic of bilateral versus one stage versus staged approach. I have one disclosure, and that is that I'm a consultant for Medtronic, and Medtronic supports a university chair in Leuven. I give this presentation on behalf of the entire thoracic staff from Leuven, celebrating this year 600 years of university, 600 years of pouring wisdom, and some Belgian beer in the heads of our students. And I give this presentation on behalf of something that we implemented since 5 years, which is the LUFT. It's the Leuven Lung Failure and Transplantation Units, which comes together every 2 weeks. It consists of emphysema physicians, of radiologists, surgeons, transplant pulmonologists, and some research team. And every 2 weeks, we discuss every new COPD patient who enters the hospital, and we decide on what is the best tailored approach for each of the patients, either his optimization by medication or rehabilitation, some form of lung volume reduction, or transplant procedure. And if possible, indeed, we do a staged approach where we send the patients first to rehab, then consider a valve, then go to surgery, and in the end, after a few years, still have the option in the younger patients for transplantation. That is, I think, the future of patient-directed care. I like to quote, indeed, your very nice story of the fable of Aesop. and refer to your nice papers, where indeed you talk in that introduction about improving the subjective sensation, David, rather that than to achieve objective improvements in FEV1, which wonders me if you believe in a placebo effect of the procedure. However, I do agree with you that it is the patient who decides. It's not oncological surgery. We don't treat images. We treat the subjective feeling of the patient to relieve symptoms of dyspnea and exercise capacity. That is the bottom line of lung volume reduction. However, indeed, a bilateral one-stage approach, especially if you look it up in literature, has somehow peaked at the end of the 90s and then disappeared over the last 20 years, probably due to the anticipated high morbidity and mortality, but also maybe to a misconception of which selection criteria should be followed for these patients. I think this brings us back to a key concept of lung volume reduction surgery, where volume is the issue and not the tissue. I come back to this, I always repeat this in my presentations, but the key concept of lung volume reduction surgery is to anticipate, to select the more heterogeneous parts, the real target areas of the lungs which are destroyed, and resect them and have the same concept during the surgery. I like to compare a two-stage lung volume reduction surgery as a very nice stroll through the Yorkshire hills and dales, which I'm quite sure that David likes that after his retirement now. And so he does a first approach. He climbs the first hills, comes back into the valley, and then, of course, like it is in the UK, a pouring rain comes in, and he enjoys some pints in the Duke of Wellington and has no interest anymore in going up to the second hill to really enjoy the Yorkshire landscape. Whereas a unilateral, one-stage bilateral LVRS seems like a majestic challenge, but comes with a fantastic, breathtaking experience afterwards. But it is true to be said that the one-stage bilateral is not in every setting, not for every patient, and maybe also not for every team. It requires excellent preparation in experienced hands, to be in good company and understanding the limits of your own setting, of your own team, and the limits of your patients. I think that is very important in understanding that there should be no dogma about always trying to do a one-stage bilateral. You need to be prepared for that endeavor. At the same time, I think that there's a lot of misconception when we talk about unilateral LVRS, bilateral LVRS, one-stage LVRS, staged LVRS. In many papers, unilateral is compared to bilateral in a sense that it is either a one-stage or a two-stage approach. Unilateral versus bilateral, it's not always used in the same wording in each paper. Also, being a staged approach varies in papers, whereas the timing between the two stages can vary from 6 weeks up to more than 1 year, 2 years, 3 years, as in literature from David. Also there's no consensus. So staged is used overall. There's a lack of trials. And I have been wondering, how can we compare this retrospectively? Because in many patients, there's an asymmetric division of the emphysema between both sides. There's probably also a reason why some patients only have one stage instead of two stage, and there are some patients who will never reach the second stage because indeed they have died or there were other reasons not to come to that second stage. So how to compare it in an objective way is very, very difficult, I think. There's also huge bias in a one stage and a bias in a two-stage procedure, whereas the one stage is probably patients without adhesions, which are quite smooth, going well, clear targets, one lobe only, whereas a two-stage might be where in the first stage you see a lot of adhesions, you need to stop, and then you only go to the second stage. And then indeed, my major comment to your very nice data, David, is how to interpret that dropout between stages. What about missing the boat indeed, as you reflected on yourself? What about missing that second stage? And here I show you some very nice graph looking into the light blue, which is the two-stage approach with anticipating 6 years improvement after the initial operation, whereas the one stage seemed to lose the battle already around three years after the procedure. However, what happened to all initial patients with an intention to treat both sides? Because here we're looking at the biased group. These are patients who were able to get the second stage. What happened to this cohort of patients who never had the chance of going to a second stage? And you can also clearly see it in David's data that where are these 190 patients between the second and the first stage? That seems to me quite a high number of patients who will not get to this second stage. And then, of course, when you're only looking at results of these second stage patients, there is a clear bias that these patients are the ones who can anticipate a second stage, who gains sufficient to go again after a few years to that second stage. So there is a bias in literature, and it's not a comment to David in general, it's a comment to literature and how, as a LVRS community, we should try to understand what happens to these patients and how to interpret these data in a more fair way. In general, I think the selection criteria that we currently follow are a bit wider. FEV1 should be above 15%, diffusion capacity above 20%, and a residual volume above 150%. Sufficient residual volume, excess in residual volume, allows you to target indeed the volume. A mean pulmonary artery pressure should be kept below 45 millimeters of mercury, measured on right heart catheterization, and patients should still be able to walk more than 140 meters. And then you have the ideal candidate. The ideal candidate is a patient with not too many comorbidities, marked hyperinflation, with a residual volume above 200% and a heterogeneous upper lobe emphysema. These are the ideal patients to also do a one-stage bilateral LVRS, avoiding that compensatory hyperinflation of the other side, if deemed safe enough to do both sides in the same procedure. So what are the surgical concepts for such an undertaking? I think it's very important to state that it should always be a minimal invasive approach. In my hands, that means a video-assisted thoracoscopic surgery, and I come back to the reason for that later on. In every patient, not in every, but in many patients, I make a bilateral plan, which means that the evening before the procedure, I study the CT and try to identify the target zones that can be resected. But I do a unilateral approach where I start on the side which is mostly destroyed. I try to estimate the volume that I need to resect, keep to my adagio, volume is the issue. I use some dynamic inflation during the procedure, which means, and there's a very small trick for that, that I ask anesthesiology only at the moment I make my first incision to stop ventilation. If you do that, there's most obstructive parts of your lung still be somewhat inflated, making it more challenging perhaps to do the wedge resection, but on the other hand, it avoids that you go too central into the lung or use not sufficient staplers to do the resection. And then very importantly, don't touch the lung, avoid air fistulization. I always try to install the patient in lateral decubitus. Why? Because I prefer this way, because then it gives me a maximal view. I use 2 or 3 ports, and I use 2 or 3 ports instead of a uniportal to be able to use the best angle of attack, avoiding any tearing on the very fragile lung. Sometimes, when it's very classic bilateral upper lobe, no adhesions expected, I do a transplant positioning with the arms going to the back, and then you just have to tilt the table to be able to operate on the second side. But however, this is more rare than the classic lateral decubitus. Here you see how we release the adhesions. We stay in the parietal pleura, and then instead of normal clamps, I use these cotton balls to do some reshaping of that volume which is entrapped in the lung that you want to resect. I do a pre-stapling attempt without compression, just to give some memory to my hand before I come in with the larger stapler, and I use the buttressed stapling to avoid fistulization on the stapling line. In the beginning, or if you're in doubt, you can do an underwater test if there's an air leak. I come back to that later. I think that's very crucial. And then I do some additional sealing. Since 2 years, of the area surrounding the staple line, first using some Pogel, and then on top of that some Neovil. So what are the trade-offs not to do the other side in a one-stage approach? I think if my first side, and I rather start on the right side when the emphysema is distributed equally between both lungs. If the first side takes more than an hour, I stop. There's probably a reason why it takes more than an hour, and patients like this should not be kept asleep too long. If there are multiple targets, I mean upper and lower lobe, perhaps a part of the middle lobe, then there is more risk of a tension on the posterior fissure, which can rupture afterwards, especially if you would ventilate the second lung for an hour, putting some extra stress on that just operated lung. That's also a reason not to continue. Same with very fragile tissue, already having an air leak or having cut several adhesions. That's also a reason not to go to the other side. If you see that your PCO2 after the first lung rises above 55 millimeters of mercury, we also stop by protocol. Also the same with vasopression increasing or need for more volume. These are extra risk factors which I do not like and after which I stop doing my first site. I give you an example. Classic emphysema patient, male, 61 years old, still walks 300 meters, had a PCI of his LAD previously, but he has a good FEV1, 37%, residual volume, 211%, diffusion capacity, very nice, 46%. We look at the CT, and there is no doubt on which targets should be resected. On the right side, that's an upper and a posterior lower lobe, and then on the left side, there's some more bullous emphysema almost on the upper left lobe and some on the posterior lower lobe. So I operate on the right side, everything goes quite smooth, and then we start ventilation. And indeed, what you can see, the tissue is so fragile, and we are looking here at the posterior fissure that just because I stapled the upper lobe and the lower lobe, there's a lot of tension on that posterior fissure which ruptures. Luckily, because this is a very frightening situation, we were able to staple it going from downwards to upwards. Of course, in this case, we would never go to the second side. I show you the chest X-ray. Day 0, you can see that indeed it seems quite crowded there on the right side. And then I think it's very important to use the shift of the mediastinum to make the cage, the thoracic cage on the right side smaller so that the remaining lung can still touch the thoracic wall and that some anticipated air leak might heal, which causes also an overstretching on that left lung with a high risk of compensatory hyperinflation already in a few months, as we have seen before. And so at 2 months, patient is doing well. You can see that that left lung is growing already with an FEV1 already of 55%. And then I went in for the other side at 2 months because that was really a target risk, not only to develop a pneumothorax, but especially to overcome or to prevent that compensatory hyperinflation. I did that left upper lobe, and then at 5 months he had an FEV1 of 71%, something that would never have been able to if I would only have touched one side. There are some cases where it is very clear before you touch the patient that you should remain to a staged procedure. Here I should show you some examples of classic heterogeneous bilateral very destroyed areas. You can see how much I resected in these patients, and then I always plan the second side within 6 to 8 weeks after that first side, because I know if volume is the issue, not the tissue, these patients will always benefit from resecting this part of the lung, and you will avoid that compensatory hyperinflation. Also, in patients with a very low FEV1 or DLCO, you should not push the patient and try to do a one stage, do it rather staged. Or in patients with a lot of cardiac or renal comorbidities, you have to avoid right heart failure or kidney failure. For example, this is a patient, FEV1 14%, 72-year-old. Of course, I do a unilateral LVRS, and I don't push this patient to one-stage bilateral with the risk of finding him on the ICU 1 week later. This is 4 hours after the procedure with an implementation of an enhanced recovery. you recover these patients within a week after such a procedure, but the one-stage bilateral in such patients would just be too much. So when to do the other side, it really depends on the morphology for me. Quite early and scheduled, dictated by the physician, I think, in very destroyed lungs, where you will always gain by removing this very destroyed tissue. In the other patients, where for another reason there was a reason to stop after one side, I see the patients back at 3 months, we do a spirometry, and then we discuss with the patient. If the patient feels like, okay, this was the anticipated plan, I want the whole lung to be operated on both sides, and I don't see any red flag not to, I will follow the patient's wish. If the patient says, I'm feeling fine for now, we schedule an annual follow-up thereafter to see and not to have the patient deteriorating too much before going to the second site. Here I give you an example of a clear overexpansion of the contralateral side. I will skip this because David already showed you this case. What is really important if you do a one-stage bilateral is the role of anesthesiology. Apart from optimal pain control for after the procedure, maintaining the arterial pressure and profound muscle relaxation, I think in patients like this, it's really important to always extubate in theater without Valsalva. But really discussing with the anesthesiologist is it if the risk is fair to do the other side, especially if you have an air leak. After finishing the first site, you should never go, I think, to the second site. And then immediately starting your enhanced recovery in this patient, also in a one-stage bilateral LVRS patients, based on an adequate pain management and an early ambulation and physiotherapy. And we have published this. Last year, we compared the 2 years of LVRS experience before implementation of an enhanced recovery with the first year after implementation. What you can see immediately at the bottom line is that the 2 years before implementation, there was always either a one-stage bilateral LVRS or an elective unilateral LVRS. What we implemented is this intermediate concept of a two-stage bilateral LVRS based on some important regulations on going to the other side or not. So stay on the safe side. And as you can see, this is just more than just adapting surgery or just going to a two-stage in case instead of a one-stage approach. You can see that all parameters significantly improved based on the holistic concept of minimally invasive surgery for LVRS and enhanced recovery. And after that, the program grew. This year now, 2024, we did 65 procedures, another 10 are scheduled, which will mean we will reach around 75 to 80 procedures because the confidence of referring pulmonologists and patients is growing. This is one of our surgical residents, Jonathan Nuts. He just did a very nice study looking at the entire cohort of 246 procedures over the last 5 years until June 4th of this year, looking at the bilateral LVRS comparing staged versus one-stage LVRS. One-stage LVRS was performed in 83 of these cases, whereas staged was performed in 32 patients, so which means 64 procedure. If you look at our experience, 26 of these 32 were performed within six of each other. I would call this an early staged procedure. If we compare the baseline characteristics of both, there's no difference between both groups, comparing the staged versus the one-staged, neither in age, gender, BMI, neither in history or oxygen use. If you look at the morphology, also there is not a major difference, but you can see in general, we go here far beyond the net criteria. We also include homogeneous and intermediate heterogeneous emphysema. FEV1 is 32%, RV 215%, DLCO 38% in the one-stage procedure. And as you can see, all these patients suffered from their COPD. So coming to the operative characteristics, and here are 4 columns because I like to compare in the column the first side of the stage bilateral with the second side of the stage bilateral. And then if you look at the one stage, you have also a first side and a second side, but in the same procedure. As you can see, there is a difference in regard to the duration of the operation, which is a bias for the one stage because in general, these operations are performed 20 to 10 minutes faster, which means that they are easier to be done. And in these patients, there was no reason to stop after the first site. Also, if you look at the amount of staplers, you can see that the staplers used in the staged procedure was higher than in the non-staged procedure. And why is that? Because probably I resected more targets than in the one-stage procedure. And this is confirmed in our detailed analysis of the targets, where you can see that the one-stage bilateral LVRS was mostly for upper lobes, whereas the two-staged LVRS was mostly for combinations of upper and lower lobe. And also in the two-stage procedure, we have seen more adhesions, not only at the first stage, but also at the second stage. Looking at the surgical outcome, you can see that the length of stay is quite equal between all procedures, whereas the second side of the stage bilateral is 2 days shorter than the one-stage bilateral. And I must say that patients in general, they recover faster from that second stage, probably because they have a bit more reserve than after their first stage. The duration of air leak in the stage bilateral is 7 days, whereas in the one-stage bilateral, this was only 3 days. And if you look at the air leak at postoperative day 1, this was present in 35% of the first stage of the stage procedure versus 16% in the one stage. And that's of course also a bias there, because probably we stopped the procedure because of very fragile tissue. If you then look at the prolonged air leak, was present in 31% of the side of the stage bilateral, whereas it was only 10.8% in the one-stage bilateral procedures. And if we look at the major complication, you can see that they are not that frequent. There's one which is surgical revision for air leak. I come back to that, which means that by protocol now, over the last 1.5 years, if a patient still has an air leak after 1 week, I go back. Even it's not, if the air leak is not too big, just because at 1 week the lung is still elastic, you can easily find the air leak, cover it up, staple it, and the patient will go home after 2 days. So you should not wait until this resolves. And then in general, but this is for the whole cohort of 250 patients, the overall in-hospital and 30-day mortality is only 1 patient, resulting in a mortality of 0.4%, including 82 one-stage bilateral LVRS. So how to prevent and manage such an air leak? Some things I already said. Don't touch that part that remains. Avoid the fissure, because there the tissue is very fragile and it's difficult, if you have an air leak there, to solve it. Do not allow any air leak at the end of the procedure. So this is what we do. We finish, we reventilate, and then I go on the other side of the drape. Together with the anesthesiologist, we look if there is any air leak. If there is any air leak, I go back to the table, pour water in the chest, look for the air leak, and try to solve it. Recently, I had a visit from the surgeons from Barts. It was a complex case. We had an air leak. Looking back with anesthesiology, twice we were able to recover, and the patient was extubated without air leak. And then a reintervention at 7 days is important. For example, in this case, I did part of the upper lobe. I took enteral part of the lower lobe. And then indeed, when I looked with anesthesiology, first there was an air leak in the posterior fissure, and secondly, there was an air leak at the ligaments. And here you can see on the top right that there is some shearing of that very fragile lung just next to the staple line, and then with flush on the lower pulmonary vein, I was able to staple that as well. This is something that's possible because I'm there at the table doing the video-assisted thoracoscopic surgery. This is more difficult if you're sitting with the robot and have no contact with the patient itself. And then this resulted in a learning curve on the prolonged air leak. These bars reflect each 50 consecutive procedures. And as you can see in the beginning, we had an air leak over almost 20%, whereas over the last 50 procedures, this resulted in an air leak of only 1 in 50 procedures. Coming to the functional results, comparing this one stage versus this early staged procedures, you can indeed see that there is a rapid increase of FEV1 residual volume drop and also an increase of diffusion capacity after both procedures. And at 2 years, the results are equal between them. Okay. So I think safety first, but if one stage LVRS can be performed, why not? If we look at the functional capacity of the patient, looking at 6-minute walking distance, the CAT score and the MMRC, there is also a sustained effect at 2 years for both procedures. And we have a prospective of these patients, so I hope in a few years from now, I will be able to share their 5 or 6 years of follow-up. And this is already a glimpse into the future. This is the results on the red of patients who had a bilateral procedure. These are 23 consecutive LVRS patients from which we had the spirometry results up to 3 years before the procedures. And as you can see, at 2 years, the patients the same levels as 3 years before their procedure. So which means that in general, these patients can gain up to 5 years. Thank you very much for your attention. I leave the rebuttal to my colleague, Mr. Waller.
Thank you, Lawrence. I think we've seen that details are important, as in any surgical field dealing with such complex patients as in the LVRS group. So I've added a survey and would be interested in the audience's opinion, also based on the presentation. In a standard patient, what would be your standard, your first approach? Would it be a unilateral or a bilateral? So while we are doing the rebuttals, please vote, and I'm interested in the results at the end. Your presentation is on, David. Yeah, you can go ahead.
Okay, thank you very much, Lawrence. So before I just show those 2 slides, we'll make a couple of points. It didn't look as though many patients proceeded with the second stage. The reason for that was they hadn't made the decision yet, and they were still happy with their quality of life. And it was about 20% of the patients died before they could be assessed for their second operation, but the overall survival was not improved by doing both lungs at one time. So it wasn't as though that would have saved them. And don't forget that nobody they were all offered the choice and kept under regular follow-up. Nobody was lost to follow-up or just abandoned. And as I've said, I think the important thing about volume reduction surgery, it's not lung cancer surgery. It's all about the patient's choice at the start. They have to be bad enough to want the operation. But for the first operation, we don't tell them you must have it done. And that's why I think the second choice should also be patient-led. I would say also that I would still do and still have done staged bilateral operations, but I have informed the patient of the potential risk. And those were patients similar to the cases that you showed, where they had very destroyed lungs on both sides with a high risk of a pneumothorax or compensatory hyperinflation. However, I kept the patient in the hospital and did 2 unilateral operations rather than 1 bilateral. So can I have the next slide? I'm not sure we can do that yet. So my question to Lawrence is, what do you do when you've had this very good result from doing both lungs at the same time, but we know that the decline is quicker? So the patients will come to you and say, I'm not feeling as well as I did. And it will be quite soon. It might not be within 2 years, but it will definitely be within 4 years. What do you do then when you've already done the operation on both sides? Do you say, we'll have to do a transplant, which is a possibility, but certainly not suitable for the majority of the patients that enter our program? And if we're then looking at doing redo LVRS, and this is the results from the unit where you trained in Zurich, where there was a 15% conversion to thoracotomy with a 14-day hospital stay, and 32% required reoperation. So this is a complex, dangerous operation, and that's what the patients are faced with if they want further volume reduction. You could consider doing a redo lobectomy, but again, Eugenio Pompeo showed that carried a very high mortality, again, possibly from conversion. You could consider endobronchial volume reduction after surgery, which is what we do, and that's what we have in store for these patients. However, we know there is a problem with collateral ventilation if they start with an incomplete fissure. I'm going to suggest something to you that you will be absolutely horrified. Consider dividing the fissure at your first operation. Now, you say you're fearful of the fissure, but presumably that's what you do day in, day out for lung cancer operations anyway. And don't tell me you don't do lung cancer operations on people with emphysema. And don't forget what you're dividing there are collateral channels. It's not functioning parenchyma as it is in volume reduction surgery. So theoretically, the air leak from the collateral channels in the fissure should be much less than the air leak from the parenchymal staple lines. And so dividing the fissure at the first volume reduction operation gives you that option, even if you do bilateral surgery, to then consider endobronchial volume reduction at a later stage. And how about this? How about when you redo, and I have had a series of these recently referred to me, patients who've had previous volume reduction surgery on both sides with a complete fissure or a not incomplete fissure. Then we did endobronchial volume reduction and divided the fissure. So we didn't go into the area where the adhesions were in the upper lobes. We divided the fissure, having put endobronchial valves into that residual lobe, and massively reduced the air leak from trying to redo the volume reduction surgery. So there are strategies to deal with the problem of redo surgery if you've blown all your chips at the first operation. And that's why we tried to spread out the benefit to avoid these situations where a patient has deteriorated probably faster than if you'd done one stage and you've still got something to offer them. So as you can see, this is what we concluded. Although the current convention at that time was for bilateral one-stage procedure, we felt, and we still do, that unilateral surgery results in symptomatic improvement, even if you just do one lung, that the stage approach to the second lung reduces the risk and the hospital stay and leads to a slower decline. The timing can be influenced by both the patient and the surgeon. This is the important point, that the surgeon has to inform the patient of the risk of delaying the decision. However, the patient is still the best arbiter. They know how they feel. They know what benefit they've had. They know whether they want to go through it again. And I still would defer to them because they determine their own outcome. And very few patients have regretted the procedure, as you've seen there, with the quality of life benefits being rolled out for several years. And even those patients who only had one operation, one side done, still had a long improvement in their quality of life, such that really they never wanted to come back and have the other side done. So that's my argument why I've done both. I still have a small cohort of patients who I would do bilateral surgery on to reduce the risk of complications in those where there clearly are problems in that other lobe. But in general, I would try and avoid heroic surgery. I don't think, despite that's our mentality, that heroic surgery is what lung volume reduction is all about. Maybe when we started, we were thinking we could get people off the ventilator, we could operate on people who would otherwise need a transplant. But I really think that the benefit of volume reduction is in the better end of the spectrum. Keep them small, relatively painless, relatively low morbidity operations, and do them again and again. I think that's where the patients get the best benefit. Thank you.
Thanks a lot, David. So Lawrence, the floor is yours again.
Thank you, David. Thank you, Clemens. Just a few slides to come back to these comments. I think in general, we do some kind of staged approach, since if there is a possibility of putting valves, if indeed that the target lobe that we identified has a complete fissure, we will go for valves first in our center. And then in many of these patients, after 2-3 years, we see an indication to go for surgery, which can even be another target at that moment. And then either to go for one stage or also in these patients for a staged approach. So in that sense, that would also be some kind of staged approach. However, in that sense being said, doing some kind of simultaneous approach is not so easy in most European countries, because we don't put the valves, it's or the pulmonologists who put them. Regarding redo LVRS, I must say that I'm very, very restrictive. Of these 250 patients, only 5 patients underwent until now a redo LVRS, 2 others are scheduled. These patients did fine, but that's a very restrictive number. I only do a redo LVRS if the target for the redo case is located in the lobe that was not operated with the first procedure. So which means that if I did the upper lobe in the first procedure, I would only treat these patients if there was a clear target in the lower lobe. And if I do a redo procedure, by protocol, it's only unilateral LVRS. I would never do a one stage in these, but up till now, I only did 5. That being said, I think identification of target lobes and targets during the procedure is really important. Where do you see the need for such a redo LVRS is classically you do an upper lobe LVRS, that segment 6 is also a bit of destroyed, and in 2 years it's completely gains volume, whereas the upper lobe remains quite small. I do more and more now when I see a segment 6 that's a bit destroyed. I already put 2 staplers on top of it just to prevent that compensatory hyperinflation on that site. I think selecting between bilateral or unilateral LVRS in that sense, or stage versus one stage, it's a different selection of patients. It's another type of patient. I think a bilateral LVRS, is it one stage or early stage, is classically for heterogeneous upper or lower lobe emphysema and patients with a clear marked hyperinflations who don't have that many comorbidities and can tolerate that indeed increased surgical. Whereas the unilateral LVRS is probably mostly for patients with an asymmetric disease, one lung much more affected than the other, or who might not withstand the more aggressive bilateral approach. I completely agree with you, David, that we should not be heroic in the setting of lung volume reduction surgery. And that's why we really identified, and I mentioned them, which are the reasons not to go to the other side when planning a one bilateral. I think keeping your patient on the safe side is important. Over 3 years, doing more than 200 patients in the last 3 years, send any patient to ICU after the procedure. Yeah, I think because we keep patients on the safe side. One stage is safe and possible. We have that with our data. If we respect the safety margins, if we do a thorough pre-op evaluation and intra-op assessment with a limited overall in-hospital and 30-day mortality. LVRS really has come of age. And this brings me to the last slide, Clemens, to consider for patients who are too good for LVRS. And I look back into data, and we looked at patients with heterogeneous emphysema, probably mostly with a story of dynamic hyperinflation, with an FEV1 still above 45% and a 6-minute walking distance of more than 450 meters. These were 5 were treated naturally. And as you can see, for the FEV1, these patients gain tremendously of such a one-off procedure. And you really can cure almost the emphysema in these patients. In general, I think we have to convince our physicians to send these patients in early enough for a thorough assessment and not wait until the FEV1 is 20%. So come to an end, going back to the fable of Aesopus with the introduction of Mr. Waller. You can say that Mr. Waller is indeed the tortoise, being steady, good, going towards the finish line to end as first, whereas I am more the hare, trying to jump higher, going faster. However, Mr. Waller, I'm not that hare. I am a hare because I'm vigilant. I respect the safety margins, and what I really believe in is to be some kind of hybrid of a tortoise and hare. I leave it to the imagination of the audience to put my head on the body of Mr. Waller. I didn't try that. It's up to your imagination. But the real champion of this debate, dear audience, is lung volume reduction surgery. We were not discussing the utility or the need for LVRS. The ESTS Society is convinced now that LVRS has its place among other thoracic procedures. And I think my colleague and me are both convinced of that, and we hope that this debate also was able to convince you. Thank you very much.
Well, thank you, Lawrence, and thank you, David, for this really excellent overview on aspects and arguments from the unilateral and bilateral LVRS. I think, as you both nicely summarized, LVRS is an important procedure for emphysema patient. It needs a detailed patient selection, and ultimately, there are arguments for both the unilateral and the bilateral approach. There might be patients which are suitable more for one approach or the other. However, there is certainly also an overlap. The audience has come to a relatively clear conclusion, and the majority is more in favor of the unilateral approach, which was chosen by 79% of the participants in the audience, and 21 opted for a bilateral approach. So I think it needs, as you both mentioned, a well-reflected decision in a multidisciplinary emphysema board dedicated to treating patients with emphysema. Unfortunately, we've already gone over time, so we're not able to discuss the pending questions. I would like to thank both of you for the excellent presentations, and the audience for the participation. And I'd like to point out our next webinar, which will take place on December 16th, and will be focused on technical aspects of advances in robotic surgery. And I hope you're gonna participate all again. Thanks a lot, and goodbye for today.
Thank you very much. Have a nice evening.
Thanks very much, Clemens. Thanks, Lawrence. Very enjoyable. Thank you very much.